right, everybody. Thanks for coming out. This is our second ASP educational event. The first one went off very well, so we decided we should probably do another one. Hopefully keep on doing them quarterly. Before we arranged this talk, we polled the providers, the hospitalist service and the team health providers to see, what do you want us to talk about? And the response, especially from the ED side, was about treatment of UTIs and pneumonia. And I think it was Craig specifically who referenced a recent FDA advisory about the use of fluoroquinolones and how first line use of fluoroquinolones for community-acquired pneumonia was out of favor, and the risk benefit just wasn't there with the adverse effects of the drugs and other things. We're also going to focus on resistance patterns. Nicholas is actually going to kind of do a deep dive into resistance related to fluoroquinolone use. So that will be a very, very interesting topic to kind of get into the nuts and bolts of like how bacteria actually do develop resistance, not just that they are, but how does it work. So without any further ado, I will introduce our first speaker. Nicholas K. is a fourth year PCOM pharmacy student. He's been with us for a couple of weeks now. He's got a couple more to go. And he'll be our first speaker, followed by Dr. Suji Matthew, who is our infectious disease physician and also the medical chair of our antibiotic stewardship program. So, Nicholas, take it away.
Hello, my name is Nicholas. So a little nervous here, but I recognize a lot of familiar faces here, so I'll try to get through this pretty easily. So just to kind of some points, what I'm going to cover today is one, we're going to talk about the FDA advisory. I'm going to go over some epidemiology and etiology as well, also resistance and why we're kind of talking about this. So to start out, the FDA drug advisory. This was released back in May by the FDA, and it was regarding the use of fluoroquinolones with certain uncomplicated infections such as sinusitis, bronchitis, and uncomplicated UTIs. And the reason why they were releasing it was because the risk of using them is probably outweighing the benefits now due to the side effects of them. So they had a couple of points in there. One is if you're going to use them, try to restrict fluoroquinolone use to patients that don't have any other options, such as a beta-lactam allergy. The other thing is if you are using them, you want to keep out a look for serious side effects, and if the patient's experiencing them, to go ahead and just stop it and switch to a different class. Some of those side effects include things like pain, muscle and joint pain, tingling, pins and needles sensations as well. Those are common issues. Also hallucinations and even confusion as well with fluoroquinolones. So moving on over to epidemiology and etiology. As you see here, I got sinusitis and bronchitis up here. There's two very, very common upper respiratory tract infections. Sinusitis affects like 1 out of 7 adults. Bronchitis, back in 2006, they had about 9.5 million people diagnosed with it. Now, the two tables below show some common pathogens associated with them. However, both of these are mostly due to viral infections and usually don't require antibiotics, which is kind of why we're focusing on UTIs and pneumonia today. So UTIs and pneumonia. UTIs, it's reported that 25 to 40% of all women in the U.S. between the ages of 20 and 40 have had at least a UTI. And it's responsible for about 6 million doctor visits a year. It's kind of impressive. So the table below, E. coli is probably the number one causative agent of uncomplicated UTIs. I think the range is like 75 to 95% of the cases are caused by E. coli. Pneumonia, I was a little shocked at this when I had researched it, but it's responsible for about 15% of deaths in children under the age of 5, and it's responsible also for about 50% of all sepsis and septic shock cases as well. So the most common pathogens associated with pneumonia are going to be strep pneumo, Haemophilus influenza, and Mycoplasma pneumonia. So resistance, got a nice little picture up there for you guys. There's three common things with resistance to fluoroquinolones. They're going to be mutations in drug targets, the accumulation, and also there are plasmids involved as well. So we're going to go into each one of these just a little bit, not too deep hopefully. So the first one here is drug targets. And this little chart here is a nice way to kind of look at where fluoroquinolones are working and how they work. So fluoroquinolones, they bind to DNA gyrase and topoisomerase. They form this complex here, which results in double-stranded DNA breaks and eventually cell death. Now, they don't target gyrase and topoisomerase equally. So in gram-negative bacteria, they actually target gyrases more, versus gram-positive, where they target topoisomerase 4. Now, the mutations will occur in those subunits in a region called this QRDR, which is the quinolone resistant determining region. That's where the actual mutations are occurring. So the next one is mutations in drug accumulation. Now, there's kind of two steps to this. Gram-negatives have a little bit, I guess, an advantage to it, really. They have porins. Porins allow passive diffusion of fluoroquinolones into the cells. Now, gram-negatives can actually regulate that and reduce the number of porins they have, obviously reducing the number of, or the influx of fluoroquinolones. Now, both gram-negative and gram-positive bacteria have this non-specific energy-dependent efflux pump. This is an example of one here. Very complicated name, I'm not even going to try to pronounce and slaughter it. So these two genes here, they're repressor genes. Mutations occur in those genes, and what ends up happening is that once those two genes are repressed, this pump, two things happen. One, it increases the activity of the pump, which is going to increase the efflux of fluoroquinolones out of the cell. And the other one is they activate genes that decrease the number of porins that they have as well, limiting the influx of genes, fluoroquinolones as well. NOR-A is just a specific efflux pump for Staph aureus. They are just for completion. So finally, move on to the last one, plasmids. Plasmids are responsible for a lot of mutations, a lot of resistance in multiple bacteria. Fluoroquinolones aren't alone to that. So plasmids produce several genes. One in particular I'm going to talk about is the QNR. It produces. QNR is found when it's transcribed, makes a protein, it binds to DNA gyrase and topoisomerase. And what it does is it decreases the binding affinity of fluoroquinolones to it, making the bacteria more resistant to them. Now, these SOS box genes as well. SOS genes help the cells to fix broken DNA. Now, fluoroquinolones cause DNA damage. So what happens is the more fluoroquinolone damage that causes the DNA to break, they cleave this inhibitor, this LEX-A here, they cleave that off, and that causes the transcription of SOS genes. And that increases the tolerance to DNA damage and also increases the repair of DNA within the bacteria. So why are we talking about this? Well, we're talking about resistance, and we're talking about use of fluoroquinolones in pneumonia and UTIs. So real quick to touch base on is breakpoints and MIC levels. So the CLSI and the FDA establish breakpoints, and a simple way to put it is breakpoints are MIC cutoff values that say is it sensitive, intermediate, or resistant. These values are determined on multiple factors. Some are PK parameters of the drug, sites of infection, as well as the wild type distributions of MICs. Now, when you guys get a culture and you send it down to the lab, they grow it out or get a sample. They send it down to the lab, grow it out to a culture, identify the drug, and run susceptibilities. And what they're going to get is a specific MIC to each antibiotic for that organism. They then take that MIC and compare it to these breakpoints, and they can say, okay, this is sensitive to these drugs, it's intermediate, or it's resistant. The whole point of that is to help physicians, nurse practitioners, healthcare providers, whether it's here at the hospital or community, to figure out which drugs they should be using and which ones they need to avoid. So, talking about that, I actually found the, I didn't put it in here, so I have a printout. The CDC tracks resistance rates and changes over the years. So this lovely printout here has resistance changes of E. coli. We're going to do a specific example, E. coli and fluoroquinolones. I can pass it around, yeah, absolutely. You can see that there. So they tracked it from about 1999 to 2012 was the last one I had. So in 1999, E. coli only had a resistance rate of about 5% to fluoroquinolones. Then by 2006, that rate continued to climb up to 23%. Due to prescribing issues, now 2012, last one on there, is 30%. Does anyone want to guess what this local area, what our resistance rate is here at the hospital?
85%.
85? Good guess. Good guess.
Not quite doomsday.
Not quite there yet, but if we keep prescribing, we may be. So this next slide here, this is our antibiogram here at Clearview Regional. I highlighted in red fluoroquinolones and also other antibiotics that are commonly used in the treatment of UTIs. Now, E. coli being the #1 pathogen, that's what we're going to focus on. The resistance rate here at this hospital for local, for physicians in this hospital, the ED, and also the local community, the resistance rates is about 35%. So that's kind of a scary thought when that's a normal empiric therapy drug that we commonly prescribe, especially when you compare that to something like macrobid or the nitrofurantoin, which only got about 7%. Now, these are susceptibilities that done as of last year, 2015. So in 3 years, it's already climbed another 5% from that, from the CDC there. And that is all I have. Is there any questions I can help answer? All right. Well, thank you very much.
Good job, Nicholas. I was nervous too. Okay, very good.
Hold if you can.
So Dr. Matthews is going to speak with us next. She's going to cover a broad range of topics. One of the main topics is just whether or not to treat, and then when you do, your best options around here for treatment choices. So, Dr. Matthews, it's all yours.
So, how to use this? Most of you here know me. My name's Soji Matthew, infectious disease here at Clearview, infectious disease physician here at Clearview. So, how does UTI occur? Again, things we all are familiar with. In case of women, it initiates with colonization of the vaginal introitus with really colon, your bowel flora, and then goes up the ureters into the kidneys where it can cause pyelonephritis. So really it's an ascension infection, starts out from the vaginal introitus and goes up. Pyelonephritis starts out from the lower UTI, can go up, but also remember you can have bacteremias that can seed the kidneys. So in those cases, you may look at a urine and say, geez, it doesn't look like an infection, and that's possibly what happened. They had a line, it caused bacteremia, and and seeded the kidneys. Again, the spectrum, 75 to 95% of the time you're going to deal with E. coli and Enterobacteriaceae, the remaining 15 to 20%, which is Proteus, Klebsiella. There are bacteria like coag-negative staph. In the urine is actually Staph saprophyticus, which is a true pathogen, can cause UTIs, especially in diabetics and pregnant women. There are a few examples where you really want to treat coag-negative staph in the urine if they truly are symptomatic. And if we can speciate it, it always helps us to know what is the pathogen. In healthy non-pregnant women, if you get Enterococcus group B strep, again, these are organisms we don't typically treat unless the individual had symptoms, it was a midstream clean cat specimen, and you did have a high colony count, then this is somebody you would want to treat as a true UTI. Okay, so here's a question. I mean, we often say it's leukocyte esterase positive. What do we mean? What are we detecting actually? The presence of?
White cells.
Yeah, exactly. So we're saying there's pyuria because it is an enzyme present in white cells. When we say something is nitrite positive, what do we mean here? Exactly. And it is enterobacteriaceae that are converting nitrates to nitrite. So really that's what we get, the information we get out of these simple tests. So the problem is leukocyte esterase can detect greater than 10 leukocytes per high power field. So it has a very high specificity, 94 to 98%. So of course, finding it is positive in the sense you do have pyuria. The trouble with nitrite test is it's fairly sensitive and specific. Of course, you're only detecting a certain kind of bacteria, the ones that can convert it. And then you need to have typically a colony count of about 10 to the fifth or more in order to see a positive nitrite in the urine. Another thing to remember in an outpatient setting is somebody has typical urinary symptoms, their urine doesn't really look infected. Think cervicitis, prostatitis, urethritis, your mycoplasma, chlamydia, the things that you may not otherwise think of. We're so focused on the whole UTI aspect, but asking a sexual history and getting that kind, eliciting those complaints, just very important because we could easily miss those. Outpatient treatment, macrobid, nitrofurantoin, still a very good choice. 100 milligrams twice a day, 5 to 7 days. You can treat your simple UTIs. You really don't want to do it if you're thinking pyelonephritis. It is not recommended. Or if the creatinine clearance is less than 30. Bactrim for 3 to 7 days, another good option. Again, the same thing that Nick covered. FDA recommends not using fluoroquinolones for your uncomplicated UTIs. And again, it's a risk versus benefit ratio. If that's the only antibiotic you can use, that's fine. But really, it is just trying to say make sure you weigh the pros with the cons. If you have an ESBL in the urine, again, if it is just a lower UTI, you could try macrobid, and if it is susceptible, see if they just have lower urinary symptoms, you may get away with just this. Tell them to drink plenty of water, basically, flush the urinary tract, macrobid could work. Phosphomycin, now some pharmacies carry it, I know it's not here in-house, but Monurol as a single dose does cover lower urinary tract infection, so that's something else to keep in mind. Fluoroquinolones, again, if you have pyelonephritis and the pathogen is susceptible, it's a good antibiotic to have for outpatient early pyelonephritis. So who do you admit? Anyone. Of course, if they have nausea, vomiting, they're not going to keep a PO. You've got to get them in. But even if they have pyelonephritis, but they seem like they're otherwise going to be okay on an oral, a quinolone is a good antibiotic. It has great bioavailability. And if you have culture data and the organism is susceptible, they should do fine on it. So 7 days again should be adequate, to treat an early pyelonephritis. So we'll move into catheter-associated UTIs. Again, we have a lot of emphasis on this. It's just with all the different guidelines to limit catheter use, remove it as soon as possible. And the main reason, again, is if you look at the statistics, 20% of hospital-acquired bacteremias arise from the urinary tract. That's huge. And to think that we would then end up treating the bacteremia and the complications that arise from it. The mortality is about 10%. Bacteriuria, that's just bacteria in the urine, in anyone with an indwelling catheter occurs at the rate of 3 to 10% per day of catheterization. So if you think of it, you're almost giving them a 100% chance after 10 days that they're going to develop a UTI, worse still a bacteremia, and then you're going to deal with that. So just impressive stats, and just a reminder why we kind of act anal about the whole thing. Do they need the catheter? Can we get it out? And then again, you will have bacteria in the urine, and that's another important thing to remember. The presence of bacteria in the urine itself should not make you get a knee-jerk reflex to stop them on antibiotics if they don't have symptoms, because the presence of bacteria is almost inevitable in somebody who's got a catheter in place. So a symptomatic use. So again, with catheter-associated UTIs, the treatment really is similar as your regular UTIs. You want to make sure they're symptomatic. Different studies compare between 10 to the third to 10 to the fifth colony-forming units. But the key is they have symptoms and signs of UTI. You can go ahead and treat it. Now, if somebody has a catheter, comes in from a nursing home, always remember to change the catheter, if that's possible, before you send a urine specimen. You'll be amazed at how many people will have a catheter in there for like 3 weeks. You are going to grow stuff, but it's going to be like 10 different organisms. It's not going to be a good specimen. So the first thing is, do they need a catheter? And if they don't need it, remove it and get a clean midstream specimen. If that's not possible, remove the catheter, put a new one in, and then send a urine specimen out. That's going to be your best bet of what's actually in the bladder, not what's on the catheter. And again, if you cannot do that for whatever reason, you cannot remove a catheter, please don't collect it from the bag or from, make sure it's from the port. Again, these seem like simple things, but you can be totally misguided with the information you get if you're not aware where it's drawn from. So all latecomers will have to answer all the questions. All right. Oh no. See? What did I do now?
That's never happened before.
Never?
Never. No.
See? All right. What I said? Okay. All right. So asymptomatic bacteriuria, again, no symptoms, and then culture growth of 10 to the 5th uropathogenic bacteria. And the person, of course, has a catheter. The thing to keep in mind is if they have removed a catheter in the last 48 hours, that too qualifies as catheter-associated UTI. So it really is important to elicit that history. NHSN, which is the National Health Safety Network, they're the ones who, sort of make these guidelines, ding hospitals for their UTIs and stuff. Now, their definition says even if you have 2 pathogens, you can still call it a catheter-associated UTI as long as they are both, of a significant 100,000 or more. All right. Moving to candidiuria, again, the presence of candida in the urine. The thing to remember is just 5% of these will develop candidemia, so really not that significant if you see candida in the urine. The suggestion is when people were treated with antifungal drugs and others just had a catheter removed, really both did pretty well. So we do not recommend just treating candida in the urine. Again, the question to ask yourself is, does this person need the catheter? Should we just remove it? And that's all they need. Now, here's a question to you all. Now, why are we so particular that we do not want to treat them with azoles or fluconazole if they do have candida in the urine? What's the concern? Anybody?
QT prolongation?
No, not as much the QT, but what we're concerned is if they have candida in the urine and you treat them, what I remember it as the 2 R's, they will get recolonized. Okay, so you've achieved nothing. You'll reculture urine, see it again in a few days. And the second thing is you're going to give rise to resistance. So if you keep using an azole for short periods, you're going to end up with the azole-resistant candida. And that's no fun because that basically means you've really got to go now to the broader spectrum antifungals.
What's the incidence of resistance?
So it depends. Now there are some candida, albicans who have pretty good susceptibility still to azoles. Glabrata is higher, so a lot of it is speciating. So right now, in somebody who's never been exposed to an azole, pretty good. Over 90% you're going to be successful in treating with fluke. So but as you move into somebody who's been on chemotherapy and taken fluconazole for thrush and other things, so it's really group dependent. So in the community folks, you have very good susceptibility. But your cancer patients, it would be pretty high. You would have a lot of azole resistance. Again, now when somebody has persistent candidiuria, which is the presence of candida in the urine persisting, do think of doing imaging to look at the kidneys, be it CT, ultrasound, make sure there's no obstruction, there's no fungal bowl, there is no other reason why they keep having persistent candida in the urine. If systemic signs or symptoms are present, think about disseminated infection, think about candidemia, and send blood cultures and do the appropriate imaging. And again, I think we just said this antifungal therapy is not recommended in asymptomatic candidiuria. Now, you will treat someone with candida in the urine if they are neutropenic or instrumentation is planned. Now, what's the reason we want to treat this group? If they're neutropenic or if we are planning to do some kind of urological procedure, what is the reason we want to treat them?
Because it may become invasive.
Exactly, because you want to target the group where you have the least these are the individuals who can easily get a systemic infection. They're neutropenic, they don't really have much to fight. And the individual who's going to get instrumentation, you could have a mucosal tear, and that local infection could become systemic. So, these individuals, yes, and the treatment is 200 to 400 milligrams of fluconazole for about 14 days. Of course, if you have susceptibility, use that data. So asymptomatic bacteria, as the definition suggests, no symptoms, and they have a specified count of bacteria. In women, we usually say if they have 2 consecutive clean cat specimens of more than 100,000 organisms, and in men, a single clean catch, voided specimen, then that's considered asymptomatic bacteria as long as they don't have symptoms. You do not treat this. If you do see it incidentally, you don't have to treat it, except in this group, pregnant, again, instrumentation if they're neutropenic or transplant. And really the logic is you're only treating people who you think have a risk of developing systemic infection. Like my mnemonic here is PINT, P for pregnant, I for instrumentation, N for neutropenic, T for transplant. That's how I always remind myself when I see bacteria in the urine, do I really need to treat this? So now, why do we treat pregnant women? If they have just bacteria in the urine but they don't have symptoms, what's the reason?
Preterm labor.
Exactly. Preterm labor is a big risk, and the pregnant women, it's their anatomy with the uterus being pushing on the bladder, etc., greater incidence of ascending infection. So we are a lot more sensitive to that, and of course initiate treatment in there. Okay, so we'll move on to pneumonia. And as this wife comes into the room and says, the hospital staff did this to you? The patient's like, no, the hospital staff. All right, so a lot of acronyms here. CAP is community-acquired pneumonia. HAP is hospital-acquired pneumonia occurring 48 hours or more after a patient came into the hospital. And what we need to remember is that this individual should not have been incubating symptoms. If they came in with respiratory complaints, then of course, it still could be community acquired. VAP is pneumonia that develops in a hospitalized patient 48 to 72 hours after intubation. Then you have aspiration pneumonia. And then you have healthcare associated pneumonia, which is individuals who are from a nursing home, long-term facility, wound care, chemotherapy patients, your dialysis patients, anybody who's been hospitalized from 2 or more days within the last 90 days. So healthcare associated pneumonia is really a lot of the patients we see in the hospital. So important thing to remember, because this is a group we can worry about staph infections a little more than the community patient who just walked in from the street without these comorbidities or conditions. So this particular group of people have a higher likelihood of staph or resistant organisms by virtue of being exposed to more antibiotics, basically. So they just have put these as a different subset. So again, the pathogens, strep pneumoniae is again significant. That's your third blue line. It's about 65%. And then always remember, just like Nick pointed out, a lot of our sinusitis, a lot of our rhinitis and pneumonias are all virus related too. In fact, in an outpatient setting, more than 85% is viral. And it is hard to tease out the two things, and everybody gets this thing of, God, I need to put them on antibiotics, but really sinusitis, such a high proportion are virus that you can just do symptomatic treatment and reassure the individual, a week to 10 days you're not getting better, we can consider antibiotics. Now, if they have high fevers, I would err on the side of antibiotics, of course, but if it's just sinus drainage, a little bit of sinus pain, facial pain, as opposed to a fever of 103, you've got to use some degree of judgment here. But just pointing out again, strep pneumo is still very common. Atypicals, mycoplasma, lower in incidence, but keep in mind here, atypicals, we don't culture it out, very few run serology, so a low number may just mean that we just didn't see it, not necessarily a true low incidence. When we say atypical, what bacteria are we talking about?
Legionella.
Good.
Because there's CDC sent out a memo now that the incidence
It's
is
increasing,
picking up.
exactly. So when we talk of pneumonias, we typically say community acquired. We have two different, we're thinking of strep pneumo and we're thinking of atypicals. These are the most common pathogens we deal with. Strep pneumo, H flu in your common group, and then we have the atypicals. Atypicals are mycoplasma, chlamydia, and legionella. So when we do this combination of Recefin with Zithromax, we're trying to use Zithromax for the atypicals, and our fear is the Zithromax is not very good for the strep pneumo, which is now acquired resistance. So the Recefin is to target the strep pneumo, which is the one that can really do a lot of damage. The atypical is usually the walking pneumonia, what we call somebody who really, isn't that sick, but these two coexist often. So you can have the strep pneumo with the atypical, and which is why we do the dual coverage. Levaquin, the good advantage is it covers strep pneumo as well as the atypical. So that is the advantage there. But that's just again to remember why we use this particular combination of drugs. H influenza again has resistance to your standard penicillin, and which is why the Recefin covers that too. So your common pathogens get covered by Recefin in an inpatient setting. You don't have to worry too much about missing it if you give it with Zithromax.
Since we use a lot of quinolones, is there any reported resistance?
Strep pneumo, yes, it is acquiring resistance, but the sap, I don't know, people shouldn't be encouraged to use more of it, but it's not, so you can still use it in the outpatient setting. It is a good drug. The reason for not using it has a lot now to do with the side effects and the black box warnings, and less with the fact that it is not a good antibiotic. But if it's good enough to stop people from using it, I'll go with the side. It's not. But it actually is a good antibiotic. It's just got bad side
It's
effects.
broad spectrum.
Exactly. It is very broad spectrum, and it doesn't really require you to think. You're like, it's good for the pneumonia, it's good for the urine, it's good for the cellulitis. You can just throw it on. When you're treating a patient, your fever, tachypnea, hypoxia, tachycardia, hypotension, 2 to 3 days of a right antibiotic, they should respond to this treatment. So when somebody has a persistent cough, try not to immediately think it's a failure of antibiotic and put them on another course of antibiotics. Coughs can persist for 2 weeks. Chest x-ray findings can stay abnormal for a month. So again, keep in mind, what are you looking at? The patient is better, the fever is better, their breathing's better, they're still having a lingering cough. Don't immediately try to bring on another course of antibiotics. So there's just something to keep in mind. Bad slide, sorry, but really, I think we've spoken about it. It is just covering an outpatient and inpatient. No one can read it, including me. But what we've spoken about all this in an outpatient setting. Zithromax is fine. You can do a quinolone if needed, especially if they have comorbidities, your diabetics and your COPDers. The quinolone, is a good drug to use. In an inpatient setting, Recefin and Zithromax, good choice. Levaquin is another good choice to use. If they're in the ICU, you want to think of Pseudomonas and you want to think of staph. So when you think of Pseudomonas, which are the anti-pseudomonal antibiotics? Name them. Come on. Shout it out, you'll know it.
We don't use it much, but
Where's the ICU nurses?
Okay, very good. So that's Fortas, cephalosporin. What else? What are your other anti-pseudomonals? What covers Pseudomonas?
Fluoroquinolones too.
Fluoroquinolones. And remember, that's the only PO option. So when I get these calls that say nothing, no oral works, the truth is if it's quinolone resistant, you're going to have to go IV. It's that simple. So quinolones, Fortas or ceftazidime, which are the others?
Carbapenems.
Very good. Carbapenems, except Invans. So Invans is a once-a-day carbapenem, will not cover Pseudomonas, but your Merum, imipenem, and then of course Dorivax will cover it. We have
How about the
Dosins.
4th generation anti-pseudomonal penicillin?
cefepime. And now, of course, we have newer ones, which I won't even go into that have come
Yeah.
out that have covered. Yeah, let's just we're not going there because Michael doesn't want to use it, they're expensive. So we won't discuss it here. If they're that resistant, you can put it in as an ID consult. Aminoglycosides, again, anti-pseudomonal, really good drug when you think of somebody who has a UTI. And I had an ID attending, again, this is anecdotal, you won't find it in literature, but he would say that a patient comes in with a UTI, you give them a good amount of IV fluids and 1 dose of an aminoglycoside, and he'd guarantee, repeat a UA in 48 hours, it'll be clear. Because aminoglycosides have really good renal levels, and that's what you want. And that single antibiotic, just does a great job. So again, we're very scared of the whole renal toxicity aspect, and while we should be, a single dose may not do as much harm as repeated. And then the thing being, again, these are things you can try and see. We don't use that much of aminoglycosides, so we're not seeing that much resistance, which is a good thing. But again, if it means we can reduce the amount of Zosyn we use, or reduce a patient's hospital stay, that kind of thing. So just something to keep in mind. But I've done it, it works. So I feel encouraged to, go on the line of less is more. If you can get somebody out sooner, why not?
What milligram per kilogram do you use?
Yeah.
So,
Qualify the
yeah, so in an so obviously if you're going gent and aminoglycoside, you're typically thinking that at least in the ER. It's harder to do it in your clinic setting, I would imagine. So you can go at the lower dose, even 1 to 3 milligrams per kilogram is fine.
For one.
Yeah, and a single dose, so about 90 to 100 in a milligram of an aminoglycoside is. And I don't think anyone's really studied it to see, or not enough people use it. People are so afraid of aminoglycosides that nobody has really come out saying, geez, if you use it, you're going to worsen, it cause more kidney failure. The point is we don't use it enough, we're scared of it, but it's a great drug, especially for urine infections. Not so good for pneumonias, but very good for urine.
But does monitoring the trough levels help?
It does,
Yeah.
and of course, if you're going to do it for more than, say, a week or 5 days, 6, you do want to monitor troughs. That's where pharmacy comes in. They do a great
Yeah.
job. It's easy. You say first pharmacy to dose and dispense, and they take over.
How about Doxy? Do you use Doxy?
Doxy is good, will not cover Pseudomonas.
Yeah, it doesn't.
Yeah, but it's a great
for
drug.
atypicals.
It's excellent. Very good drug.
It
Very
used to be cheap, but now it's expensive.
Yeah, it is, but it is a very good outpatient drug to have. So, okay, we'll move to pneumonia treatment. Just saying a few things. Zithromax 500 milligrams for 3 days is actually adequate for your regular pneumonia for the patient that you see in the clinic. If it's Legionella, it's about 7 days. You want to go a little longer, and you want to do a 1 gram loading dose on day 1. This year, IDSA, Infectious Disease Society, and the American Thoracic Society have said 7 days therapy for hospital-acquired and ventilator-associated pneumonia is enough. You just need to go longer if you think they have, persistent respiratory failure, etc. But we used to do 10 to 14 days, so now we have come down to saying 7 days is enough. What is the value of the PCR nasal swab? We do this MRSA swab in some of our ICU patients. Thing to remember is that it has good positive predictive value. So you do a swab and you start somebody on vancomycin thinking this could be MRSA pneumonia. If the swab is negative, it helps tell you very, very low likelihood this pneumonia is due to staph, MRSA. So its positive predictive value is, not, again, if it is positive, it could be MRSA, it may not be, but if it's negative, it helps reassure you to say, really, I can stop vancomycin and I don't need to continue it on. MRSA risk factors, we know this again, it's end-stage renal disease, injection drug use, recent influenza, recent antibiotic therapy, and then again, if your local prevalence is high, yes.
Is there any reason to isolate these people with a positive swab who don't have pneumonia?
Now I'm getting into hot water. So these are hospital policies, right? Every hospital picks something that they think will The short answer studies have shown no. If they just have a swab positive, you're okay if it's not a draining lesion and that kind. But I think part of the reason a lot of hospitals do it, and they've done cost comparisons, the amount of money we waste in gowns and things of that nature, but I've gone to different hospitals, and I think hospitals pick a policy based on fear factor, based on comfort level, based on, yeah, I mean, so it is hard to, but if you just want the scientific basis, no, there really isn't a true reason to isolate somebody who has a nasal swab. But I think the concern in a unit, I forget, in Clearview, is it even on the floor or just in the ICU? We isolate everybody, okay. So I think basically the rationale is that you're going to spread infection among patients, and yeah, I know, but
And our
again.
nurses won't do
You
that.
isolate the positive.
Our nurses are too good, right? Our nurses won't do
No, but that's why you wear a gown if you see the isolation, then you limit the chance you're going
that. It's on
to
their nose, unless they're going to be picking their nose. And
Exactly.
That's what they all
There's no one from quality control. Who's here? No one's here from quality control. See, they probably be like, do not change the rules here. Our hospital's doing pretty good. So this is really, it really is. Hospitals pick up these policies, but yes, I mean, I
All
understand.
nurses are swabbed.
No,
No.
and never should be. Really, they'd all, you would be not a good idea.
Yeah, we don't want to know.
Okay, aspiration pneumonia, the only key thing I do want to say is, if you are going to use flagyl, try to restrict it for below the diaphragm infections that are anaerobic. I'm not a fan of using it above the diaphragm, and the simple reason is first of all, the failure rate is higher, about 50%, because there are the microaerophilic and aerobic streptococcus that is actually resistant to flagyl. So what is a better anaerobic choice? Clindamycin above the diaphragm.
Those
Would you say?
Zosyn.
Zosyn, yes. Zosyn's great. All your beta-lactam lactamase inhibitors, so Unison, Zosyn, carbapenems are good for anaerobic, but of course Cleocin or clindamycin, very good above the diaphragm for pneumonias. If you are going to use flagyl above the diaphragm for an aspiration pneumonia, then you want to have penicillin-type drugs on board to cover the gram-positive anaerobes. So it's a lot of overkill. So my personal preference is below the diaphragm, use flagyl, above, just use the other antibiotics that you have. All right, false of the quinolones, true or false? Cause tendinitis and tendon rupture.
True.
And which tendon most likely?
Achilles, right?
Yeah, Achilles tendon. And who is at greatest risk is patients who are on steroids, patients who are very athletic. And the tennis player who's going to be doing a lot of jumping with the quinolone on board, very likely to get a tendon rupture. The problem too is it can happen a few weeks after you stop the quinolone. So even up to 3 months, studies have found out that these patients will have tendon rupture. So again, keep that in mind. Quinolone's a good drug, but okay, let's go. Peripheral neuropathy. True. Increased risk of seizures, increased intracranial pressure, pseudotumor cerebri, and toxic psychosis. True. Very good. We're having a trend here. Confusion, tremors, hallucinations, depression, suicidal thoughts or actions. Very good. May worsen.
The drug.
What did you say?
We'll end up not using the drug.
See, this works now. Fear mongering. All right. May worsen weakness related to myasthenia. Which is the other drug that can worsen, antibiotics specifically, can worsen weakness related to myasthenia? Very good, aminoglycosides. So, and now Zithromax does it, but to a lesser extent. But myasthenia, this is a black box for quinolones, just use it with caution. Prolongs QT, again, of course, quinolones do it. See, you guys know this. All right, name the drug. Most used drug, but that's the whole point, is to try and reiterate it. Half-life of 70 hours. Which drug? Commonly used.
Not
No, not. No. 70. Zithromax, very good. So when we talk of half-life, the way to remember is if you're going to dose a drug twice a day, 3 times, 4 times, the dosing pattern is based on its half-life. Zithromax, why we think a 3-day course is adequate is it does stay in the system a very long time. So it is a very long half-life, and just good to remember. Drugs that cause QT prolongation. Very good.
And
What-
Zithromax.
Very good. So both those are drugs to keep in mind that cause QT prolongation.
Wait, quick question. All macrolide antibiotics could do it? Erythromycin can do it?
Yeah, they all cause QT, yes, they do. Drugs to treat atypical pneumonia, very good. Quinolones,
Doxycycline.
very good. Just 3 drugs for atypical, remember that. Zithromax, quinolones, and doxycycline.
But how often do you encounter QT prolongation?
Not very, not really, not. But your patients were on immunodrone, and a lot of you just have to be very vigilant that you, that you could. Again, have I really, I've seen this very, very infrequently myself, but I think it's just important to keep at the back of your mind that, somebody's already got arrhythmias and issues, just be wary that your antibiotic may potentiate those. Drugs causing delusions and hallucinations.
Quinolones.
Very good. You're paying attention. This is good. Flagyl, quinolones. And I'm specifically talking antibiotics because there are a lot of drugs. Penicillins do it, and sulfonamides do it too. So you really have, and Flagyl does it. Delusions, hallucinations. Name the drug that causes your cerebellar findings. Ataxia, typical MRI findings that include T2, hyperintensity of the cerebellar dentate nuclei, and involvement of other areas of the brainstem and corpus callosum. Which one?
Flagyl.
Very good, very good. So you are officially graduating Harvard. All right. So it is true now. We always knew that drugs that penetrate the CNS can cause CNS side effects, but now they're actually given a term antibiotic-associated encephalopathy. And so keep that in mind when you use certain drugs. This doesn't mean don't use antibiotics, because we were just told in this talk all of them have side effects. No, the point is these are side effects to keep in mind. We don't often think of it. We don't often think that is it the antibiotic now that's causing the patient to go even more psychotic, So again, just something to keep at the back of your mind. So, strain of 2000, you are the next class of drug-resistant bacteria. And as humans continue to abuse and overuse antibiotics, your ranks will swell. So go out there and mutate. And remember, that which does not kill us makes us stronger. All right, that's it. Thank you. Questions?
I have a question. I came late, sorry. We're just on meeting.
Well, I will write you up and we'll tell you what.
No, we're seeing patients, but I just came with your catheter associated. Do you usually do urine white cell count to really correlate between colonization and actual infection?
And it helps. And so one of my pet peeves. So her question is, do you always do urine white count in a patient who has a catheter? So one of my pet peeves is people who send out urine cultures but not UAs. So always correlate symptoms. Yes, Tiffany's like, yes. So do correlate symptoms. Do please send out a urine specimen, yes. And if they have greater than 100,000 bacteria, or if they have significant pyuria, it just helps for you, reassure you this is what you're treating instead of, so absolutely.
Because actually we're not producing new antibiotic. I mean,
we've got to be very careful about what we have. Yep.
So if you have a patient with community-acquired pneumonia and you admit them for, say, observation, treat them with Rocephin and Zithromax, what's the best outpatient regimen to transition them to?
So that's a very good question. So the way I look at it is if they've stayed at least and gotten their 3 days dose of Zithromax, I would probably go with like a 3rd generation cephalosporin and get them out, because their atypical part is covered. So if they haven't, they've just been 2 days and now they're out discharged, I would give them at least 1 more dose of Zithromax PO and then
transition to a PO 3rd generation cephalosporin.
So 5 to 7 days for community-acquired pneumonia is adequate. All right.
For your Klebsiella pneumonia regimen, what would you advocate?
So 3rd generation cephalosporins, again, are we talking outpatient or inpatient?
Inpatient.
Inpatient, so starting out, Rocephin, good choice, 3rd generation cephalosporin, and then of course...
Monotherapy?
Klebsiella is fine for monotherapy, unless of course then, and even if it is an ESBL organism, you would just move to a carbapenem. There really isn't a lot of any need for dual coverage for Klebsiella.
How about immunocompromised hosts?
I don't necessarily do dual coverage for an immunocompromised Klebsiella unless they are persistently bacteremic or they are clinically not responding, but most of them will respond to a single agent.
Aminoglycosides are considered.
So for pneumonias, it is not my first go-to because aminoglycosides don't have very good lung
Penetration.
levels. And then if they have any kind of aspiration or abscess, aminoglycosides just don't work very well. So I don't tend to go towards aminoglycoside if I'm thinking Klebsiella pneumonia. But if it is UTI, I would. So it's really looking at the source. So that's again, third generation cephalosporin, Zosyn is a good option. And then, of course, by then, typically, if they don't respond, by then, if they're sick enough, they've grown out something in culture, you can use that to guide your therapy.
Thank you.
Mm-hmm.
Do you still think Pseudomonas needs double coverage for a pneumonia?
No, and that's a good question. So short answer, not, again, the really sick cavitating pneumonia in the hospital, just a Kipnick on the vent from that, I would do dual coverage. But if they come in and their sputum's growing out Pseudomonas, they're on the floor, they're otherwise stable, single coverage is good. There's actually a role of tobramycin inhalation is something you could also try, and really no reason to do dual coverage. Some of it is guiding antibiotic choice of dual or single based on how they're responding. Bacteremias with Pseudomonas, we do double. And then, of course, if it is CNS endocarditis, we tend to lean more towards. It's again just making sure the antibiotic gets to the organ of concern.
What are the typical bacteria that cause the cavitating pneumonias?
Staph is notorious. Now, strep can do it too. But then you have almost all cavitating. You've got to think anaerobes. Klebsiella can do it. So, but then the individual is usually an alcoholic.
Yeah.
Alcoholic, immunocompromised, these are the ones. For a cavity to develop, the host factor, something about it did play a role in it typically.
But it's always best to give broad spectrum and then pending
De-escalate.
cultures. If they're sensitive, then we can downgrade, right?
Yes, as long as you do that. Some people will just leave them on that broad spectrum till death do us part. We'll just keep them on it. If less is good, more is better. That's really not. But you are correct. It's always better starting out broader and de-escalating as long as you remember to do that.
Remember.
Yes, de-escalate is the key. All right?
I just wanted to point out that it's not usually, we don't usually run anaerobic cultures on any respiratory specimens.
That's true, and I think that's a good thing to point out. It's hard to grow, and it's not something we would. So the idea when you see aspiration or a cavity to cover for anaerobes is exactly for what Tiffany pointed out. Is you are not going to see it in culture. You may be misguided in thinking it isn't playing a role, but it is just worthwhile to cover it. If you see a cavity, you see aspiration. It is coming from the mouth. The mouth has a lot of anaerobes, and you've got to cover for them. So, all right. Anything else?
It would be nice if we knew that it was aspiration pneumonia.
Then you would be looking
Well,
for
I mean, we would just know better what we would treat oral
But would
flora more like a pathogen as opposed to just normal flora.
But if you, I guess the question is, so when they sent a sputum culture, do you all get any indication why it's drawn or nothing? Okay. But if they did put it in, does it even come to you all? That's the question. Would it?
What, an
Like if they
anaerobe?
put the reason of pneumonia aspiration on their
yes.
requisition, it
Yes.
would? Okay.
Yeah. As they order it, if they put in the notes that, it's an aspiration pneumonia or ruling out aspiration pneumonia, then yes, we would be able to.
Okay.
know that. And sometimes we can actually see food from when they pull out the
Wow.
specimen on the slide, you can see the food
Oh, that's, yeah.
sometimes, yeah.
I think that's why, I think with the sputum, I think we need to get a gram stain too, to differentiate colonization from an actual infection.
Yeah.
Yeah, so you can
And they
get some
do,
culture.
but y'all don't quantify gram stains on sputum, right? We don't do the 10 to 5th, or we don't quantify, right, gram stains of the sputum. We
Like
just,
the organisms?
yeah.
No.
Yeah. So we
It's
just,
just few, moderate, many.
yeah.
Because actually, you'll be chasing a colonizer and it's gonna cause more problems.
I mean, you're right. I think the key to remember always is don't send a culture, don't run a test unless the patient has symptoms and you know what you're going to do with the information.
Well said.
The worst thing is to get a culture and you ask them, why'd you send it? Well, I have it here now. It's like, why'd you go looking for this? Because now you have an ESBL that's doing nothing and now you're wondering, should I treat this? So try not, ask yourself the question, I'm going to get information that I need to know what to do with, and so be careful when you send cultures out. It's not that more information is always better, it can be very confusing. So, and then the worst is when you send a culture and then you're asked a question, should I treat this? And my question is, did you send it because you thought it was a problem? Then yes, because at this point we are wanting to treat it because we respected our reason of the symptoms that were concerning, So that's again just something to keep in mind. All right.
Good talk.
Thank you for coming.
Thank you, Dr. Matthews.
Oh, I should thank Michael and the pharmacy department. Michael takes a lot of trouble to get the food together, to get all this together. And
We're not, there's food.